All right, let's jump right into this explainer. Imagine you're drawing an animated sketch mapping out the body's most critical pathways. Well, the radial nerve would absolutely be one of the most fascinating train lines to draw, hands down. Today we're going to sketch out its entire anatomical route, from its origins high up in the shoulder all the way down to the fingertips, and we'll explore its massive clinical implications. So, looking closely here, notice the green line in our sketch. That represents the radial nerve as it twists right around the humerus, the main bone of the upper arm. You can see it's basically a delicate wire completely exposed against a hard surface, which, as we'll see in a minute, sets the stage for a lot of potential mechanical trouble. Think of this as our route map for today's journey. We'll hit the axilla and upper arm, check out the spiral groove station, move down to the forearm and hand branches, look at clinical signs of injury, and finally, recovery and surgical repair. Part 1. Axilla and upper arm. Let's start our journey at the very beginning of the line, right up in the shoulder area. Okay, so the radial nerve actually originates from the posterior cord of the brachial plexus, pulling fibers from the C5 to T1 spinal roots. It kicks off its journey running just behind the main brachial artery. But here's the crucial point. Before it even crosses the humerus bone, it gives off its very first branches to the long and medial heads of the triceps muscle. Then it just slips right out of this upper shoulder area through a space called the triangular interval. So, why does this early branching actually matter? Well, an injury really high up at this proximal level is going to profoundly affect your ability to extend or straighten your elbow, and it'll completely knock out sensation via the posterior cutaneous nerve of the arm. But as we'll discover, most of the common injuries actually happen just a bit further down the track. Part 2. The spiral groove station. Let's see what happens as the nerve leaves the axilla and wraps tightly around the bone. As the nerve courses through the spiral groove of the mid-humerus, it sits right up against the bone. This makes it incredibly susceptible to compression. I mean, if you've ever fallen asleep with your arm draped over the back of a hard chair, maybe after a few drinks, this prolonged pressure can literally block the nerve signal. It's classically called Saturday night palsy, though honestly, you definitely don't have to be at a party to get it. Because the branches to the triceps broke off higher up the arm, your triceps still work fine, but everything further down the line, completely derailed. But external compression isn't the only danger here. Take the Holstein-Lewis fracture, for example. In this scenario, the humerus breaks in a spiral pattern near the distal end. And right at this spot, the radial nerve is tethered in place as it pierces the lateral intermuscular septum. Because it literally can't move out of the way, the nerve can easily be entrapped or even lacerated by sharp, displaced bone fragments. It's a really bad spot. Just to put that risk into perspective for you, while the general risk of nerve palsy with a typical humeral shaft fracture is roughly 8 to 12%, a staggering 22% of Holstein-Lewis fractures result in radial nerve palsy. It's a highly precarious anatomical bottleneck. Part 3. Forearm and hand branches. Now we reach the elbow, a critical junction where our single train line splits into two distinct tracks. Okay, let's dive right into this fork in the road. The nerve divides into a deep branch, which eventually becomes the posterior interosseous nerve, or PIN, and a superficial branch. The deep branch is purely for motor function, meaning it controls the muscles that extend your fingers and thumb. The superficial branch, on the other hand, is dedicated entirely to sensation, running down to give you feeling on the back of your hand and that web space between your thumb and index finger. Let's sketch out exactly which muscles are powered by which part of the track. Right before the split, the main radial nerve fires up the brachioradialis for elbow flexion and the extensor carpi radialis longus, which pulls the wrist up and slightly outward. After the split, the deep pin branch dives under the supinator muscle and powers the extensor carpi radialis brevis for central wrist extension, the EDC for straightening your fingers, and those various muscles that extend and abduct the thumb. So it's doing a lot of heavy lifting. Part 4. Clinical signs of injury. So, having mapped out the normal anatomy, what exactly does it look like when this vital transit system breaks down? The hallmark clinical sign is what we call wrist drop. Because the extensor muscles completely lose their power source, the wrist permanently flexes forward, just hanging flaccid. But, this isn't just a cosmetic issue. It completely alters the biomechanics of your entire hand. The domino effect of wrist drop is actually fascinating. You might think, well, my flexor still works, so I can still grip things, right? Wrong. Without the ability to pull the wrist back into extension, your flexor tendons are entirely slacked.
They lose all their mechanical advantage. If you try to grip someone's hand with your wrist flexed downward, your grip is incredibly weak. Furthermore, without the finger extensors, you literally cannot release an object once it's in your hand. You essentially become trapped by your own grip. Wild, right?
As this quote from orthopedic surgeon Tom Quick perfectly highlights, we are incredibly lucky that the vast majority of radial nerve injuries, like those at the spiral groove we talked about, occur below the branches that supply the triceps. Triceps function is absolutely crucial. Without it, you couldn't reach up, you couldn't push yourself out of a chair, or even stabilize your arm on a table. Preserving the triceps is a massive functional advantage during recovery. Part 5. Recovery and surgical repair. Let's move to our final topic and see how we can build strategies for restoring function when the nerve gets damaged. So most compressive injuries, and even many fracture-related ones, do actually heal spontaneously. When the nerve regenerates, it does so at a rate of about 1 millimeter a day, and it brings muscles back online in a highly predictable step-by-step sequence moving down the arm. Doctors can literally track this regenerative tide. First, the brachioradialis returns. Next comes the ECRL, pulling the wrist back but slightly to the radial side. Then, a month or so later, the fingers can straighten, and finally, the thumb regains its extension.
However, there is a strict biological clock ticking here. If the nerve doesn't regrow and restore function within 12 to 18 months, the muscle tissue itself begins to irreversibly degrade. At that point, waiting just isn't an option anymore, and surgeons have to step in and perform what are known as palliative tendon transfers to mechanically restore function.
And this is where absolute surgical ingenuity comes into play. If a patient is stuck with permanent wrist drop, surgeons will literally steal a working muscle and repurpose it. They take the pronator teres, a robust muscle normally used to twist the forearm, detach it, and reroute it to the paralyzed extensor carpi radialis brevis tendon. Suddenly, when the patient fires their pronator muscle, instead of twisting the arm, it pulls the wrist up into a functional, extended position, completely restoring their grip strength. It's a real game changer. It really is a marvel of anatomy. Looking at our complete sketch of this delicate biological wire, it leaves you wondering, how does something completely exposed against a hard bone hold the absolute key to our mechanical ability to grasp, to let go, and to connect with the world around us? And when it fails, the brilliance of both natural regeneration and modern surgical reconstruction is truly something to behold.